Welcome to today's webinar. We want to first thank you for making the time out of your busy schedules to join us today, whether it's early in the morning or late in the day, depending on where you're calling in from. And also thank you if you are dialing in or viewing this on demand after the fact. We welcome you. We are continuing our journey along the Rural Nursing Innovation Series today with two wonderful presentations. Before we get started, I would like to just share a brief housekeeping as we will have two presentations today. What we are going to do is hold all Q&A until the end of the session. So once we complete the first presentation, we will open that up for some questions. We will hold those questions till the end if you want to add them to the chat or Q&A at any time in your Zoom panel, so you don't forget that. Please feel free to do so. At 9:30, that would be 9:30 Eastern or Central, sorry. We will start our second presentation followed by Q&A as well. Once that's done, if there's any additional questions for either presenter, we're happy to take those on your behalf. Now I have the pleasure of introducing our first presenter today. Dr. Tamara Keefner is an assistant professor at the University of South Dakota Department of Nursing. She has been in healthcare for over 35 years. Dr. Keefner's passion for suicide prevention began while working in a behavioral health unit and realizing the lack of resources for those experiencing suicidality. She has dedicated her career to understanding suicide, mental health outcomes and empowering the community to help save lives through education and training. I'd like to turn it over to Dr. Keefner.
Thank you, Stacey.
You're welcome.
If I can,
let me see.
It says I don't have.
Okay, you should be able to try it now, please.
Okay.
Great.
There we go. How's that?
Perfect. Thank you.
Okay, well, thank you. So thank you everybody for joining. And this is my presentation is on a concept analysis that I did on acquired capability for suicide. Here we go. And with the evolutionary method of the concept analysis, these are the 6 steps. And I have highlighted step number 6, which is identifying implications of analysis and future development of the concept, because this concept just really still is in need of development, and there really isn't a specific definition that we can apply to it. So we will talk about that. First, we start with what we know about suicide. With all that we do know about suicide, what's concerning is that the rates are continuing to increase, particularly in rural areas. In 2020, the latest statistics we have, we see that in the last 20 years, that rates have increased by 46% in rural areas. And we also know too that virtually all suicide attempters will experience suicidal thoughts, but not all who think about suicide will attempt or die by suicide. And so our big question is what moves a person from having thoughts to wanting to attempt? Many of the common risk factors that we know are related to or associated with suicidality are mostly have been tested and shown to be more associated with suicidal thoughts and weakly associated with suicide attempts. So this analysis was to try to dig in a little bit deeper to see what the newest theories actually tell us about that transition from thought to action. This diagram here is from a different concept analysis I did on the concept of suicidality in general. And what we know about that is that we know that suicide progresses along a spectrum of thoughts and behaviors. So we know that this diagram kind of shows how they are distinct but yet related phenomena that require different interventions and assessments. And the thing that's important here is that the intent to die is very important, which we found out in our analysis. So the stronger the intent, the more likely an attempt, or the intent to die, the more likely there will be an attempt. So we have plenty of opportunities within our intervention to intervene at different levels of the suicidality spectrum to be able to prevent that progression towards a suicide attempt. But that leads us to newer theories that have been developed to help us understand that progression. The interpersonal psychological theory of suicide, also known as the IPTS or the PTS, was the first to conceptualize the concept of acquired capability for suicide and informed the ideation to action framework. Now, there are other theories that have been developed over the past decade, and capability for suicide is the defining factor for most of these, which all these theories focus on to differentiate ideators from attempters. But this analysis, we focus mainly on the IPTS that was developed by Joyner, since he was kind of the first one to develop this idea of acquiring capability. And it also kind of led to a new framework called the ideation to action framework. So this diagram kind of shows us, this is just kind of an overview of the theory itself, very simplified. Each category or concept is broken down into separate risk factors, sorry. So first we have thwarted belongingness. This is just the feeling of not belonging, and then there's perceived burdensomeness, which is just, pretty much being a burden to others, feeling like a burden. And then we have capability for suicide. Now, by themselves, neither one of these are a concern. Maybe they are a precursor to passive suicidal ideations. But as you can see in this diagram, when thwarted belongingness and perceived burdensomeness overlap, we have a desire for suicide. However, Joyner has proposed that the desire for suicide is not enough for a person to act on those thoughts or that desire. Because suicide is kind of a scary and painful thing, a person needs to acquire the capability to enact pain on themselves. So with acquired capability, you can see as it overlaps with thwarted belongingness and perceived burdensomeness, with that whole interaction there, that is what will move a person from thought to action. Now, he also asserts that this theory can answer all suicides, no matter gender, race, culture, anything. He feels that this should answer all suicides. Now, it's kind of important to think about later on when we get to implications for research. Now, the capability is what we're focusing mainly on Joyner's. There are three other theories within this framework, but because Joyner was the first to do that, to bring this idea to the table, there's more research done on his theory. So that's why we focused on his alone. So we have the attributes, which start with habituation, the opponent process. So the capability to enact lethal self-injury is acquired over time, described by the habituation and opponent processes. In a nutshell, this just means that the effect of pain stimulus declines with repetition. So it's kind of desensitizing the person to the thought of inflicting self-harm. And over time, they would experience, through this habituation, this repetitive process, they will experience elevated pain tolerance and fearlessness of death. And then ultimately acquiring capability for suicide and having that capability to attempt. Sorry, having a little problems with my clicker here. Then we have the antecedents and consequences of what acquired capability is all about. So the antecedents are basically the risk factors. So the antecedents that we came up with, so the literature that we reviewed for this concept was very difficult to decipher because it was just kind of not real consistent. So, but we were able to break it down into some themes. So here, what the main theme was painful and provocative events. These experiences are posited to activate the habituation opponent process. And from the review of the literature, again, like I said, it was just a complex web of experiences. But the themes that we came up with, we'll start with self-harming behaviors. Now, with self-harming behaviors, we have direct association and indirect association with acquired capability for suicide. Now, the direct association we know are suicide attempts and non-suicidal self-injury. Non-suicidal self-injury is a little bit more straightforward because we know that as people self-harm, they're doing that for cathartic reasons. It provides a temporary relief of any type of emotional stress that they're going through. But what didn't make sense to me, but I had to include it here, is a suicide attempt. Now, they say that having a suicide attempt acquires the capability, but then just a few minutes ago, we said that you need to acquire that capability before you can attempt a suicide. So there are different ideas with that. There are other ways that a person can attempt suicide if they have been under the influence of a drug or alcohol, or if they're spontaneous and it was just a spontaneous thing that can happen. So there's that. And then there's the indirect association. Eating disorders are an indirect association. The thought behind that is that starving yourself to death can be a painful thing. After a while, that person starts feeling more content and more comfortable with that feeling of emptiness and starvation. Also, with eating disorders, if they have experienced more PP, the more painful and provocative events they've experienced while dealing with an eating disorder, they will have higher increased acquired capability. And then we have substance abuse. And substance abuse is indirectly associated with acquired capability, depending on the type and method of drug use. For example, IV drug use was shown to be directly related to acquired capability because poking yourself with a needle takes some getting used to, and it does is associated with painful and provocative experiences. And also with other substance uses, the person may be a little bit more likely to engage in activities that they normally wouldn't. So that is the indirect association. So if you combine all of these with emotional dysregulation, pain tolerance, or impulsivity, and low positive body investment, we have increase in acquired capability. Next, we have exposure to violence. Exposure to violence comes in two different themes as well. interpersonal violence, and childhood trauma. Now, with interpersonal violence, that showed to be pretty interesting as well, because with interpersonal violence, you need to have a perpetrator and a victim, right? So we found in the literature that perpetrators who also enjoyed viewing violence committed by others had high acquired capability, while those who committed violence towards someone and they were just the perpetrator, they scored lower. But additionally, women who experienced intimate partner violence scored low on acquired capability, but those who fought back, meaning they were also a perpetrator and a victim, scored higher. So this I just found interesting because it suggests that painful and provocative experiences may increase acquired capability only to the extent that the person is involved and actively engaged rather than being a passive victim of violence. Then when we looked at childhood trauma, there was a lot of research, many articles that we reviewed that talked about childhood trauma. Now we know that childhood trauma comes in many forms. You have emotional abuse, physical neglect, and sexual abuse. Now the literature was very inconsistent with all of these. But the one consistent thing that we found was that childhood sexual trauma or abuse was more closely related to acquired capability of suicide, where the other types of abuse were more associated with the desire for suicide, but not acquired capability. But of course, if you have the more trauma that you experience as a child, the higher your acquired capability will be. Then we have distress tolerance, which is the capability to persist during traumatic experiences, such as provocative work experiences, such as veterinarians who are exposed to euthanasia, firefighters, first responders, and surgeons performing surgeries or witnessing unexpected patient death and attempting resuscitation. And then, of course, there's military combat. The important thing to consider here is not just the frequency of experiencing these provocative work experiences or painful and provocative experiences together, but we also need to look at an individual's perception of the event. So in other words, an individual who subjectively perceives an experience as less of an impact. For example, they may just be very stoic and strong and may not appear to be affected by the event. They're likely to engage in more events that are provocative, which would increase the acquired capability. And conversely, those who perceive a painful and provocative experience as more negative and be more likely to avoid, because it is more negative, they'll be more likely to avoid those types of experiences. Then that is associated with lower scores of acquired capability. So high levels of distress tolerance are associated with higher levels of acquired capability. And then we have the consequence, which would be acquired capability depends on where the person is at on the suicidality spectrum. But according to the IPTS theory, acquired capability must be combined with the desire to die by suicide to enact a suicide attempt. So in this diagram, the ultimate consequence would be a lethal or non-lethal suicide attempt. But again, that depends on where they are at with thwarted belongingness and perceived burdensomeness. All right, so what are the implications? How am I doing on time? Do I have about 5 minutes left or 10?
Yeah, if it's about 20 after, so we have 10 minutes before we need to start the next session. So if you want to leave a little bit for Q&A
Okay,
before we
I got 2 more slides left, so I can get that
Oh,
done in 5
perfect.
minutes. All right, so what are the nursing implications here? Well, we know that prevention and intervention is not a one size fits all. We need to go beyond just simply asking the question, are you having suicidal thoughts? Okay. We need to understand where they're at on the spectrum of thoughts and behaviors, and understanding that there is a spectrum and that they can go from one end to the other fairly quickly. Risk factors and assessment of these risk factors and interventions require specific idea of where they're at on that spectrum. We need to have a comprehensive approach of asking beyond the thoughts and asking about their pain, if they've experienced any painful or provocative experiences. So there are a lot of social and cultural factors regarding the fear of death and pain tolerance. And we also know that we need to understand how they perceive those experiences. And the research implications, the IPTS is not the only theory in the ideation to action framework. So I feel that we probably could have had a more succinct concept analysis had we looked at the other theories. But I think that there needs to be some way to bring them together a little bit to develop better assessment tools. And the other thing that we found was that most studies were cross-sectional and they lack diversity. Now, this is important because at the beginning I mentioned that Joyner says that he thinks that this theory should be able to answer or explain all suicide deaths. But it's kind of hard to determine whether it does or not because of the lack of diversity within the research that is currently available. Longitudinal and qualitative designs are needed because acquired capability is supposed to be acquired over time, and it also can be subjective to change over time. So we just don't have enough information there to determine that. And PPEs are very broad, and there's no operational definition that exists. And there is inconsistent use of the acquired capability suicide scale and the fearlessness about death scale and antecedent measures. So we're still not real clear on the effectiveness and the predictability of this concept or theory due to those research limitations. So that is all I have. And we have some time for questions.
Yes, thank you so
Okay.
much for your presentation. At this time, if you have any questions for Dr. Keefner, you can go ahead and add that to your Q&A or chat. If you'd like to raise your hand, we can also unmute you and you can ask your question directly. There's always an incredible amount of information that's shared in such a short amount of time, which is wonderful that we have the opportunity to hear this and share this with our audience. So if what we'll do, if you don't have a question right now, and something does come to mind during the next 30 minutes, if you want to hold on to that, following our second presentation, we can circle back and you can share your question with Dr. Keefner at that time.
Yes, Stacy, you have a question?
Sure.
Can you hear me?
Yes, we can.
Thank you, Doctor, for such a presentation. I have a few questions. the data that you showed, the 46, so on prevalence, is it global or regional? And is the magnitude differs from one region to the other? Then there's abbreviation that you use on the antecedents and consequences. PPE, what does this one mean? PPE and ACS. And I didn't understand well how interpersonal, what do you mean by interpersonal violence as far as antecedents and consequences is concerned on suicide?
Okay. Yeah, so the PPEs is the painful and provocative events, experiences. So that could mean just about anything that a person would perceive as painful and scary. Okay, something that would cause fear or anxiety. Comes in many forms. It could be very different for everybody because we all perceive situations differently. Interpersonal violence is anything that would require a perpetrator and a victim that would be that would cause harm to one person or a group of people. And again, that could come in many forms for people too, because we can look at interpersonal violence. But in this particular case, the interpersonal violence where we looked at people who committed crimes, assaulted other people and caused harm, physical harm, and intimate relationships, violence against women is kind of what our particular definition of those were. And then there was another question that you asked that I didn't quite catch at the beginning.
I believe the question related to, is this a global study or is this US based?
Yes, we looked mostly at English written, but most of the studies were European and American, but that is one of the biggest limitations of this of the research involved in particularly with this theory, is that it's not it's very limited in just probably most likely Caucasian, also college age students and elderly. So it is not very diverse as far as culture and global studies. So it's very lacking in that area. So we need more. We need, it'd be great to do some type of a study in Africa, for example, on suicidality and acquired capability. Because like Joyner said, he thinks that this would, no matter what your culture or your genetics, this should answer all suicides, but we don't know that. We don't know that because we don't have enough data to support that at this time.
We do have a question from another individual. Does somebody with suicide ideations have to have all the criteria that you mentioned in order to have acquired capability?
That's a very good question. According to the theory, yes, they need to have all of those. The more painful and provocative experiences they have experienced, or the more trauma that they experience from that experience, will indicate a higher chance, a higher risk factor for a suicide attempt. But according to the theory, they also must have that desire for suicide. Okay, so for example, I could experience the same type of trauma that another person would experience, but if they've already had that desire for suicide, they may be at higher risk than I would because I've never thought of it before. Okay, does that help? Does that answer your question?
Yes.
Okay.
Thank you. If there are no questions, we will conclude our webinar today. I would like to once again thank you for putting us on your calendar. We appreciate the time, as we know everyone is incredibly busy. So thank you, everyone. Have a wonderful rest of your day.
Yes.
Take care now.
Thank you. Bye-bye.
Bye.